Dr. James Eubanks, are you available?
Yes, I'm here. Thanks so much.
Hello. Okay. Until you get your slides ready, I'm just going to go through your introduction, if that's okay.
Okay.
All right. So Dr. Eubanks is a resident physician, PGY3, in the Department of Physical Medicine and Rehabilitation, or PM&R, at the University of Pittsburgh Medical Center. He earned his MD at Brody School of Medicine at East Carolina University with distinction in research. He additionally has a Master of Science degree in Sports Science and Rehabilitation. In 2015, Dr. Eubanks completed an 8-week medical externship through Northwestern Feinberg School of Medicine's Department of PM&R at Shirley Ryan Ability Lab. He was awarded the first place 2016 Sarah Baskin Award for Excellence in Research for his work with James Atchison, investigating the use of comprehensive interdisciplinary pain rehabilitation program to reduce chronic opioid use among patients with persistent pain. In 2018, he won the Medical Student Research Award at Brody School of Medicine for his work with John Norby, which included the expansion of a required 4-week combined neurology, physical medicine, and rehabilitation clerkship program to address clinical and health systems knowledge gaps for fourth-year medical students. Dr. Eubanks serves on the United States Bone and Joint Initiative Spine Subcommittee and Musculoskeletal Education Coalition, which seeks to improve MSK education in the U.S. medical schools. Along with Dr. Elizabeth Fretz, he's co-chair of the American Congress of Rehabilitation Medicine, Lifestyle Medicine Professional Group, which focuses on the use of health behavioral change in rehab. Continuing his pursuit of clinical research training, he was accepted into the Association of Academic Physiatrists, NIH-funded Rehabilitation Medicine Scientist Training Program, where he's investigating a novel rehabilitation program for patients undergoing surgery for lumbar spinal stenosis. Dr. Eubanks serves as an instructor in the University of Pittsburgh School of Health and Rehabilitation Sciences Primary Spine Practitioner Certification Program. With that, I would like to welcome Dr. Eubanks. Thank you for joining us today, and we look forward to your talk on telemedicine and physical medicine and rehab.
Great. Thank you so much for that introduction. All right, so I'm just going to share my presentation here. Okay. All right. So we will start. All right, does that show up okay?
Yeah, looks good.
Perfect. Okay, so I'm going to be discussing telemedicine in physical medicine and rehabilitation. And I just want to say that I truly appreciate all of the organizers of this excellent event and the co-presenters who have done a wonderful job laying the foundation to better understand some of what I'll be discussing. Okay, so no disclosures here. So the outline is we'll discuss telemedicine in physical medicine and rehabilitation, or PM&R. We'll look at the context of where we are today, the definitions and some of the evidence base. We'll look at something called mobile health, or mHealth, which I think is integral to the advancement of telemedicine, and we will see its further maturation in the years ahead. And we'll look at how COVID-19 has really been an accelerant for change. So looking at this educational publication from 1815 is truly interesting to note one observation that was made. Students today depend on paper too much. They don't know how to write on a slate without getting chalk dust all over themselves. So it's interesting to contrast that with where we are in the context of COVID-19 really accelerating our use of telehealth. So let's discuss telemedicine. So first of all, what is it? This is the remote delivery of healthcare services and clinical information using telecommunications technology. And we have sort of discussed this in the previous talks, but it's really extending the traditional boundaries of clinical care that matters here. This is a great quote by one of the attending physiatrists at the University of Washington in Seattle. It's important to remember that the alternative to telehealth for many is not in-person care, but no access or barriers. And that's a theme that I think we've nicely touched on today as well. So importantly, telemedicine offers a cost-effective way to provide clinical care while addressing such barriers as access and transportation limitations. And that's something we don't want to lose sight of as we consider its rapid implementation. There are some novel benefits to telemedicine that really augments care. It's not just a matter of discussing replacement of care with a pandemic such as the one that we're experiencing right now, but rather it does add benefit to our traditional care that we deliver. Many clinical interactions between physicians or clinicians and patients in rehabilitation medicine are amenable to telemedicine. That includes triage, so initial encounters determining what level of care is actually needed, follow-up visits, so that's the reassessment of progress, particularly ADLs and function, which we can do nicely in the rehabilitation world using telemedicine, and providing reassurance, medication updates or changes, and therapy questions. All right, so telerehabilitation. The application of telemedicine to rehabilitation may be called telerehabilitation. This includes the clinical care traditionally delivered in person as part of the team-based rehab approach. And it's not limited, but may include physiatry, physical therapy, occupational therapy, speech language, and neuropsychology, which are part of the traditional team on the inpatient rehab side. But I would also like to emphasize and add our consultants. All of the specialists that we work together with to provide comprehensive care are integral in this way. So there are three common mechanisms we might think about. We integrate these usually through our electronic health record. There's some of those requirements have been waived with the pressing needs of COVID-19, but they include video conferencing, image sharing, which for rehab would be more specifically looking at like wound care and spinal cord injury, and then data transfer, that is health pertinent information that we share between a patient and clinicians. So telerehabilitation may enable delivery of care with populations who have neurologic and musculoskeletal conditions, patients with impaired mobility and reduced access, which we touched on earlier, patients with neurologic conditions, including stroke, which was nicely emphasized previously during our conference today, as well as spinal cord injury, traumatic brain injury, and things like ALS, to monitor symptoms and responses to treatments that we deliver, and things like burn patients during acute rehabilitation. This facilitates development of interprofessional care plans, and that's really important because that can include things like post-operative follow-up needs, as well as co-management with specialties such as psychiatry. So let's ask the question, what are patients after? So they want a clinical assessment. Is this something that we as the telemedicine or telerehab clinician can manage ourselves, or do we need to refer? And that's an important initial question. We also want to know, do we have enough information to diagnose the condition, or is a further workup necessary? Patients want unbiased information. They want evidence-based options and reassurance where benign conditions are involved. They also want a consideration of cost effectiveness and accessibility. So nicely, these are 4 things that telemedicine can help us address. So let's look at the evidence base. Where are we? Well, we can start at the top with a Cochrane review. This is from 2015, so pre-COVID, but interactive telemedicine. And the authors here indicated that the research at that time was suggestive of a use and value of telemedicine for managing things even like heart failure. And can it help us improve our control of blood glucose in those with diabetes? So that's a nice stepping stone for us as we enter this COVID-19 era. Now, what about the feasibility specifically in rehab? So fortunately, a group at Spalding in Boston looked at this, and they found that rapid expansion of telemedicine as occurred during the sort of March-April period of this year was well received by patients and physicians, and that's crucial. this suggests that it's feasible. So this looked at the satisfaction element from patients, and you can see that the overwhelming response was favorable. All right, now how about something a little more complex like post-operative follow-ups? So in this case, Pediatrics published in 2018 looking at the use of telemedicine as a first op visit for knee arthroscopy in adolescents. And importantly here, they found that there was good agreement between measurements of motion and incision evaluation, so that wound care aspect, between telemedicine and outpatient visits. And patient education was part of this. And the study demonstrated that telemedicine has the potential to really provide convenience and, again, access, which is crucial here. All right, so a big question that we all have is, how well does the use of telemedicine correspond to inpatient clinical assessments? So we can look at this actually in the musculoskeletal exam in something fairly complex like a femoroacetabular impingement syndrome. And the findings showed that a patient's self-performed examination was more accurate for the diagnosis of FAI than traditional examination. That's pretty remarkable. So this may help us inform the use of telemedicine, particularly as we ask this question related to the parallels between clinical examination in person and through telemedicine. So one of the things that I think is important here is if we look at kind of a standardized clinical exam for an FAI syndrome, this is a chart that was devised. A lot of these are passive, right? So it's clinician directed. And what we see when we check out the self-administered exam complement is that there is a little bit more active involvement from the patient standpoint. So we see a single leg stance, we see a squat, both three-way and single leg. And so while we are replicating some of the passive exams to the best of our ability with a telemedicine visit, we are also adding other means of assessing a patient's condition, and those involve the patient. And so I do think that the active participation of the patient in the clinical exam is something that is quite novel to the use of telemedicine. Now, my personal sense is that we're going to learn from this experience that there's probably more ways to involve patients during the physical examination process than we're currently relying on. And telemedicine is a mechanism through which we have highlighted this difference, which is that if you involve patients a little bit more during the physical exam, there might be new and different kinds of information that we actually extract from that experience. I want to segue for a moment into mobile health. I think that mobile health is going to be a component of our advancing knowledge and practice as it relates to telemedicine. So mobile health, more than a single lead EKG. It was excellent to hear how the Apple Watch, for example, is capturing some undiagnosed atrial fibrillation. Mobile health, though, is medical and public health practice supported by mobile devices to address healthcare needs. And if we continue on here, we will see that there are a number of organizations, including the WHO, that are actively involved in this discussion. And so there are some traditional limitations in the face-to-face interaction. This can include, as we mentioned, the radius of care or accessibility. And so we can extend our accessibility or our radius of care by using things like telemedicine and mobile health. Interestingly, the fact is, in 2020, more people in the world have access to digital technologies than toilets. And that's a remarkable fact to consider. It's something that we really need to own as healthcare professionals in our understanding of how we can reach and connect with patients. So this is a little bit dated already. Looking at 2015 information here, we see that at that time, 84% of doctors were using smartphones on the job, not just for personal use. So there's been this remarkable uptrend, and this is all pre-COVID. And all of the indications are that we have continued to increase the number of persons who are using these technologies since COVID-19 has happened out of necessity. All right, so mobile health, again, dated information. So we imagine that this has increased, but 325,000 health applications were around in 2017. M-health messaging, mobile health use can increase patient engagement, again, outside the clinic by extending that radius that we mentioned earlier. Increase self-management, as we also discussed during the telehealth discussion about the musculoskeletal exam. And also self-management and education tools are enhanced by the use of things like mobile health, and perhaps can even help us improve quality of life and monitor symptoms. So what types of applications are there available to us? There are lifestyle-oriented apps that we really track progress. That includes things like diet, weight loss, exercise that all of us care about regardless of what our specialty is. We have patient-oriented apps that help patients manage their medical conditions and personal needs, and perhaps even identify early symptoms in the course of their disease. We have clinician or physician-oriented apps that help us better manage patient care needs and provide references or educational information for patients. And then disease management, which is really where the telemedicine sort of intersects with the use of mobile health. So appropriately designed apps may extend behavioral change and lifestyle recommendations. In this case, we're talking about rehabilitation or physiatry. And they may also extend changes in habits and adherence, which is a particular area of interest that is improving patient adherence. They may also involve an interdisciplinary care team aspect to really strengthen the relationships needed to best manage patients. How do we make this happen? So we have one great example here in Pittsburgh, really led by Dr. Brad DiCiano, who is primarily a researcher. He first piloted the use of a mobile health system called I'm Here, the interactive mobile health and rehabilitation system, which uses smartphone capabilities to better provide data exchange between physicians and patients. And he first looked at this with spina bifida patients and really asked the question, how can we extend the clinical encounter? And that's what this really comes down to. I would like to sort of frame the importance of telemedicine and mobile health in the era post-COVID, where we use this to augment and extend the reach of our clinical care. So I'm Here allows data collection of particularly important elements. That includes medications, patient nutrition, their exercise habits, their day-to-day mood. It gives them the option to be reminded about things. In the case of spinal cord injuries, such as spina bifida patients, something that's really useful here that we found through Dr. DiCiano's work is that you can remind patients of supply needs. So, for example, if they need to straight cath, if they are getting low on supplies, you can actually track that information through mobile health technologies. But also importantly, and as is popular in non-health applications as well, you can tap in on patient goals and rewards. So I do think there's something really valuable about the use of mobile health that will ultimately improve patient-reported outcome measures and give clinicians more insight into what's happening with their patients. So if we get a little bit more granular with rehabilitation management, the experience that Dr. DiCiano and his team have found is that it can help with skin care and wounds, and that would be sort of using images to share between the patient and their physician. So if you can imagine that a patient with a spinal cord injury has a skin wound that's developing, they can snap a picture using a secure program, including the I'm Here app as an example, and send that immediately to their physician instead of waiting. So say this happens on a Thursday night or Friday, and they can't really get to their outpatient clinic until Monday. That's enough time for a problematic wound to evolve to the point where it needs immediate addressing. However, if we can more rapidly get that information to our physician, it might be able to mitigate more expensive levels of care. This includes things like bowel and bladder management, again, supplies, as I mentioned previously, ADLs, or activities of daily living in our function in daily life, but also allows opportunities, as probably many are already familiar with, in just communicating with your physician or clinician to keep them updated. And then, of course, appointment reminders. So Dr. DiCiano has looked at specific cases. This is one case that, again, looked at the spina bifida population and found that they saved a significant amount on medical cost using mobile health technology, as you can see here. All right, so where are we now? We're at the point where we do have enough data to actually perform systematic reviews, and this group did that and found promising indications that mobile health applications, specifically in rehabilitation in this case, should be considered and implemented as feasible. So we'll take a step forward and look at COVID-19 as an accelerant for change. I was very fortunate to be involved in this particular group that looked at the immediate impact of coronavirus and the resulting adaptations in PM&R, medical education and practice. And we found that the adaptation from traditional patient care to telehealth was notable and included 86.5% of physiatrists using telemedicine during the pandemic. And there was a massive shift in our medical education to virtual didactics, with roughly 92.5% of residents participating. This contrasts with only about 20% using telemedicine prior to the pandemic and 20% of residents and fellows participating in virtual didactics. So that's a massive shift. All right, so some of the pragmatic questions that we have is, how do you actually conduct a relatively complicated clinical encounter using telemedicine? And fortunately, Dr. Gutierrez, who is the chair now at the University of Texas in San Antonio, she is a PM&R physician, and she led this group that looked at this question, and I wanted to share some things with you here. So you can see how going through a regular physical exam, such as inspection, palpation, range of motion, special testing, initially that may seem quite daunting, like how do we actually participate when we cannot physically touch a patient? And one of the considerations here is to document what the patients can do. So as long as there are normal findings, that's a sort of foundation from which we want to start with any kind of clinical encounter. And then if we look a little bit further, what we'll notice is that we can enlist an assistant from the use of telemedicine to help us with tests that traditionally would be performed by clinicians and physicians. And I would just remind us during this part of the discussion that previously we did show that the self-assessment portion of the physical exam in the case of femoroacetabular impingement syndrome, or FAI syndrome, was not only feasible, but actually improved upon sort of the traditional collection of studies that we will do in the clinic So I think that this is an element we need to consider, which is enlisting persons who are in the environment with the patient, even if they're non-physicians. They can be coached to do some very crucial examination maneuvers that give us good information. With that said, we do not know that telemedicine replaces the in-person exam. And there are certainly aspects of the in-person clinical visit that are not replaced during telemedicine. But what we seem to be learning is that we can extend our reach here. We can improve access, and we can perhaps triage and reassess patients once we have enough baseline information about them. And so telemedicine is a tool, and its use is only as good as the applications that we devise. So as we consider telemedicine, I think there's a lot of room for optimism. And at the same time, we want to understand that moving forward, and especially post-COVID-19, we are going to better refine our understanding of how it fits on the full spectrum of care that we provide as physicians. I appreciate your time. I want to thank our host today. I want to thank the fellow panelists who did an excellent job really preparing the foundation from which I was able to share the information that I did. And I welcome any questions at this point.
Thank you, Dr. Eubanks, so much. And with time to spare, I actually have a question about like the wearable devices, if you have any idea about like how accurate and useful they are in terms of research and monitoring patients.
So that the wearables is certainly going to be another integral component to where we move from here when it comes to sort of the joining of mobile health and mobile health or telemedicine and mobile health. And I think that that's an area where we're really still collecting a lot of data.
Mm-hmm.
It's exciting to hear that, for example, the Apple Watch, which I do have myself, potentially has the ability to capture symptoms that patients are having or concerning findings with consent, and give that information to physicians who can then decide how to use it intelligently. That's going to be the big question here. There's a lot of data I think we can collect, but ultimately we've got to know what to do with it.
Mm-hmm.
That's the big question. There's a lot of research occurring right now that is exciting, and will hopefully over the next few years tell us more about how to see that intersection happen, which is the data coming in a way that is clinically useful, because that's kind of the whole paradigm of the signal and the noise, right? Like there's lots of signals coming in, and then how do we figure out what is important to actually listen to? I can't really quantify at this point where we are with that. But that's okay, because COVID-19 has provided an environment where there's more time and energy and research attention going into these questions.
All right. For another question, do you believe that through telemedicine, there will be a shift for rehab programs to become at-home rehab programs?
Ultimately, yes. I think that we will find there are certain types of rehabilitation that is probably just as effective at home. What we might find is that it's a little bit of patient population dependent. So there will be some people who exhibit certain characteristics that are very amenable to home rehab programs, and that those patients will probably do very well. So it will probably turn out that we need to select which patients are likely to thrive under those conditions and get that to align well for them. So those who need more in-person coaching, for example, should probably find a pathway that suits those needs. And then those who are very amenable to what we can do through virtual coaching will uh, sort of correspondingly go in that direction in terms of their care.
All right. Okay. Thank you so much, Dr. Eubanks. Your talk was very interesting, especially the access of like to digital care in the poor populations. I believe that was a question that someone asked in a previous talk.
Yeah,
So, I mean, more access to that than to toilets. That's remarkable.
yeah.
So thank you so much for your talk. And with that, we'll be moving on.